Welcome, Dr. Una Lee. She is a section head of urology and renal transplantation in Seattle, and the urology physician lead for Virginia Mason Franciscan Health. Board certified in urogynecology and reconstructive pelvic surgery. She also directs the URPS fellowship program. A Stanford grad with training at the Cleveland Clinic and UCLA, Dr. Lee specializes in pelvic floor disorders, neuromodulation, and complex reconstructive surgery. She leads PCORI funded research on urinary incontinence, serves on national guideline and specialty boards, and volunteers in Uganda to train surgeons in fistula repair. As a leader in women's health, she champions patient centered care and systemic change. And we are so delighted to have you talking with us today. So take it away.
Thank you. Really nice to be here. This is a topic that's near and dear to my heart, and I hope I can share some good learnings that are practical and give you some updates. So we'll get started. It's a packed session, and I know that clinicians like that because you just want to get all the good info and kind of be all you can for your patients. So we're going to talk about urinary incontinence, partnering with women with pelvic floor problems. Here are my disclosures. Most recently, I was the vice chair of the American Urologic Association guidelines for the urinary syndrome of menopause. So we're going to talk a little bit about that during the session. So the learning objectives are providing clinicians with an overview of urinary incontinence from a patient-centered approach and reviewing the literature on what matters to patients and how we can meet their needs better and counsel them on these issues. So urinary incontinence, it's a big topic. It's a common problem. It's embarrassing. People sometimes don't want to talk about it. The myth is that it's a normal part of aging and that nothing can be done, but that's actually a myth. And there's a lot that we can do. There's often a delay in seeking care, often years. People kind of suffer for years before they get help. Highly prevalent. It impacts daily life and quality of life. And there's a real direct cost, billions of dollars in healthcare and in other expenses. So we've got to acknowledge the problem. We've got to confront it head on. So what are the etiologies? What are the underlying reasons? It's multifactorial, but one of the common ones is childbirth injury. There's a picture in the top right of this screen that's like the baby's head going through the pelvic floor, and it does change things. It changes the support. And while people heal, and it is, a natural phenomenon, it does affect things. So it can, there's de-innervation of the pelvic floor. There are aging and hormonal changes. Anything that increases intra-abdominal pressure, obesity, COPD, asthma, is going to affect it, as well as connective tissue disorders. And so if you look at the other image on the bottom right, this is a pelvic floor as someone is nulliparous through multiparous. And so you lose some of that muscle support and some of that function. So big picture, the two most common types to know about are stress urinary incontinence, leakage with physical activity, jumping, coughing, sneezing, Zumba, moving, versus urgency incontinence. You get that urge to go and you're rushing to the bathroom and you might leak before you get there. Very common, both across the lifespan. Many women have both, which we call mixed urinary incontinence, but sometimes it's one or the other is predominant. We always like to delineate why or what type they have, or what's their predominant bothersome one, or what's their more frequent one, because the treatments target one or the other, and some target both. So it is like kind of step one to understand and define in urinary incontinence. So stress urinary incontinence versus urgent incontinence. Urgent incontinence is also, overactive bladder. If you think about stress urinary incontinence, you're leaking because the urethra is not holding back. It's decreased urethral resistance. Whereas overactive bladder, the bladder is overactive and it's contracting without your permission, and the bladder signaling is overactive. You can have mild, moderate, or severe. You can have, something that's very bothersome or not bothersome, something that's manageable or not manageable. And, I've done a lot of patient interviews and qualitative research in this field, and what matters to women that they emphasize over and over is their quality of life and what's impeding their quality of life. But you can always ask them, what matters to you? What bothers you the most? What are your goals? Right? When it comes to urinary incontinence, those are some of the salient questions. So the evaluation is a history. You want to know by history and physical exam, what risk factors do they have? What is the severity of their symptoms, right? Have them describe it to you in their words. And what's the level of bother? I often say, how much does it bother you on a scale of 1 to 10? And they'll say 12, right? Or they'll say 2 or 3, right? Or somewhere in between. But then you'll get a sense of kind of where they're at. On exam, you want to look, for stress urinary incontinence, you actually, with a moderately full bladder, you'll have them cough, or sometimes I have them stand and jump. And when you see the leakage, that's a positive cough stress test. That's stress urinary incontinence. I also test or look for vaginal atrophy. We look for prolapse. We look for other contributing factors and diagnostic data. Certainly, if they have symptoms of a UTI, then you need to evaluate for a bladder infection. Patients with overactive bladder urge incontinence often have asymptomatic bacteriuria as a coexisting issue. Another thing to look at is a post-void residual by bladder scan, just to make sure they're emptying well. Most women empty well. It would be a small percentage that aren't emptying their bladder and are retaining. You could think about urodynamics and cystoscopy. These are more higher level tests to really look at the function. Cystoscopy is an anatomic scope to look at the lining of the urethra and bladder, really to really evaluate hematuria or screen for bladder cancer, right? It's not a routine for urinary incontinence, but if you have some other factor, can be considered. This is one of my favorite handouts that I go over with patients because it's a visual tool. It's a visual representation of the diagnoses. On the left is stress urinary incontinence. On the right is overactive bladder and urge incontinence. And in the middle, you just say that they're mixed, right? That they're both. I like for them to see this so they can understand both the diagnoses and which one they have. And then it goes over all the treatment options, non-surgical options, surgical options, clinical trials, first line treatment, second line treatments, third line treatment, sort of like from less invasive to more invasive. And so that they, number one, so they can understand the two types. And number two, so that they see all the options and it gives them hope. It gives them hope that, oh, I've done this, but I haven't done all this. And it gives them a little bit of a check, like a way to check things off. Like, oh, you're working on this, but we think about this for the future. So we're going to go over all these options in this talk. I also kind of look at the middle too. It says reduce risk factors. So I go over these with them as well, like understanding the issue. Do they need to work on weight loss? Do they have to work on smoking? Things like that. And then that little picture in the middle is it a urethral problem or a bladder problem or both? So they can kind of understand what we're targeting. So again, I've listened to a lot of women and their satisfaction and dissatisfaction with urinary incontinence. And one of the things they want to know is they want to know all their options and the pros and cons of each. They don't want to be parceled out one treatment and then never know the 10 other options. So I think that's important for people to be like, first, we've got fluid and behavioral modifications. There's a lot of things you can do just in your lifestyle. There is something called an incontinence pessary. Pessaries are generally for prolapse, but there is some options for incontinence. Pelvic floor physical therapy, first line, mainstay, really effective, very safe, very therapeutic. So we talk about that. Medication options. There are procedures called urethral bulking. There's surgical options, often a sling surgery with their own tissue or with mesh. There are neuromodulation procedures, primarily for overactive bladder and urge incontinence, and clinical trials. So big categories of options so that they know there are lots of options. This was a study that we did, again, learning about the patient perspective on urinary incontinence. And this is something they're very self-aware. They adjust their lives. It can be isolating, but they're very self-driven to manage their urinary incontinence and also help others. It's kind of one of those things where they grew to accept and manage, but that there are helpful avenues that can improve their symptoms. So conservative management, fluid and behaviors, that's sort of the foundation of urinary incontinence work. They talk about pad use. We talk about moderating fluids. We talk about strategic voiding, sometimes preventative voiding, timed voiding, voiding before it's too late. Sometimes they avoid activities or restrict some fluids when they're out and about. Another good option is a bladder diary, right? To get a sense of what's happening, get some data, and then see the triggers. What's happening when they're leaking, what's going on. Tobacco cessation is a big one because coughing raises the intra-abdominal pressure and it puts more pressure and it causes leakage. And so quitting smoking is one of the best ways to manage this, and it's another important factor to consider. Some people leak with chronic cough, and we can treat the leakage, or really we could treat the chronic cough. So I have a few patients who we really target that cough, those incidents in the coughing. That's really the factor that leads them to leak. This is a big one, obesity and weight loss. So obesity is a strong risk factor for urinary incontinence. It's a little bit stronger for stress predominant mixed urinary incontinence than urge incontinence. And you have an increase in BMI, you're going to have an increased risk in urinary incontinence. And at the same time, both surgical and non-surgical weight loss has showed significant improvements in prevalence, frequency, and symptoms of urinary incontinence. And I like this study. This is the PRIDE study because it showed that even modest amounts of weight loss were sufficient for significant urinary incontinence benefits. So I'd like to give patients sort of hope that you don't, I know you have big goals, but you can do small gains and make a big difference on your incontinence. So pelvic floor physical therapy, it is a very, very effective first line treatment for urinary incontinence with high levels of evidence and grades of recommendation. This is low risk. It's not going to cause harm. It does require a motivated patient. And there are studies to show that if your doctor or your clinician tells you it's going to work, it's going to work. If the doctor tells you, oh, physical therapy is not going to work for you, then it's not going to work for them. So we have to be positive and encouraging on this, the benefits of pelvic floor physical therapy. Um, as like I said, the data is very strong and they can, part of it is, it's not just Kegels, right? It's working with a certified pelvic floor physical therapist to not only confirm that they're doing it correctly, but how to use it in their life, how to apply it. And it's also just that feedback, that accountability. And I always tell patients, it's like investing in you for the rest of your life to make sure you have the skill and you can use it for this condition. And sometimes people are using it preventatively. People are using it treatment wise, early. You can get on it early, you can do it later. It's just one of those things where the more we can encourage it, I think we would really do a service for patients. Um, there is a pessary. Again, like I said, it's usually a prolapse issue that we're using a kind of a space occupying support to help support the pelvic tissues, but it can also use to be support the suburethral area under that urethra. You've patient selection. This is a symptomatic patient with a desire to avoid surgical intervention. Sometimes it's not tolerated due to poor tissue quality or poor vaginal compliance. Sometimes it's someone who's maybe not done with childbearing and they want sort of a temporizing measure, but it's high satisfaction, low complication, and it has to be fit by someone who knows how to do this. Sometimes there's a ring and then there's like a little, again, a support that goes into the vagina. And again, it sort of supports that urethra close. Sometimes patients self do this with like a large tampon, a super tampon, and that gives them a little support under the urethra. And there were some commercial products over the counter. It was called the Poise Bladder Support, where it had some kind of plastic support in there. There are some medications that are off-label for stress urinary incontinence. Duloxetine as a noradrenaline and serotonin reuptake inhibitor. It was indicated for stress urinary incontinence in Europe, but not approved in the US due to the increased association with suicide. Probably the most helpful thing is vaginal estrogen, as it may improve urinary incontinence and has great benefits that we're going to talk about later. Imipramine is off-label as well, but it's a tricyclic antidepressant, and it does cause some bladder relaxation and increase outlet resistance. And so some people have been using it off-label for mixed urinary incontinence. You'll also notice, again, sometimes alpha agonists are used, but again, it also has some complicating factors and it's not a good long-term issue. Patients may ask you about CO2 laser. And this is really a treatment for vaginal dryness, vulvovaginal atrophy, and it is usually a pulsed laser, which is kind of targeting that collagen and support structure. It is a kind of a cosmetic procedure in a sense, but it's not covered by insurance. It'll be an out-of-pocket cost. There was a FDA warning released in 2018 about the kind of labeling and marketing of this, and that there are some complications. So we generally don't promote it for urinary incontinence, but it is useful for people with refractory vaginal atrophy. So we're going to talk about some stress urinary incontinence procedures. One of the most common worldwide procedures for stress urinary incontinence is a mid-urethral sling. This has been FDA approved since 1997, so it has a long track record. It's safe, effective outpatient surgery to provide suburethral support. There was a history of complications that still can happen because it is a mesh. It is a mesh graft. But overall, it is a safe and effective procedure. It is long-term, durable, with good success rates. And there are, like I said, there are some complications, so people need to be appropriately counseled. I would say I have treated a lot of women with vaginal mesh complications over the years, and there are unique risks when you put a mesh graft in the vaginal tissues. Um, and it can cause pain, dyspareunia, erosion, exposure, and infection. And so really it just comes down to patients being well informed, having a good relationship with their surgeon. And also it really pointed out there is some gaps in variability in patient understanding of pelvic floor problems. And we should always do no harm and believe patients and partner with them to improve their symptoms and quality of life. So some people want to know what are the non-mesh alternatives, right? What are the other things that are not a sling? There are slings that are made of your own tissue. You can harvest it from the lower abdomen, called the rectus fascia, or from the leg, the fascia lata. And this is sort of a surgery we've done for many, many years. It has good long-term durability. It's just a little more invasive than the kind of traditional mesh sling, and so you really have to counsel someone appropriately. And we select, have appropriate patient selection. But it is um, an excellent procedure with good outcomes. So we have good outcomes with success and patient satisfaction. Another kid on the block is this, what's called polyacrylamide hydrogel. The trade name is Bulkamid. Urethral bulking has been on the market for many, many years, but this one got FDA approved in the US in 2020 after over 10 years of use in Europe with good 3 to 7 year durability. What it is you've got an injection in the urethra that's just creating more of a watertight seal. And it has 60, 70, 80% success using patient-reported outcomes. It can be performed in the office or in a surgery center with a brief anesthetic. It's a non-particulate homogeneous gel, so it's not little beads that go away over time, which was the prior bulking. It's something that's really been a great additional option for women who want treatment for urinary incontinence. Sometimes they have a small risk of transient urinary retention, but it's pretty rare. And this has been, again, a great option for women. This is a systematic review that shows good objective and subjective success rates, good safety profile. And then this is our own personal review of data as we've done this for about 5 years now, and we're having good outcomes and good patient satisfaction. There's also clinical trials, cell-based therapy for stress urinary incontinence, where their own cells are getting harvested and grown up by the company and re-injected into the urethra. This has been an ongoing effort to get this to collect data so that it can be FDA approved. It's still in clinical trial status. And so we hope that this will be another option for women in the future. This was, this was a 2 year collaborative national project on engaging women on what matters to them. I led this project, and we were, again, trying to understand what the patient needs and what they want and have them help with the research efforts in urinary incontinence. And we learned a lot. We learned what their patient-derived and prioritized research questions were. They want to know about risks. They want to know about recovery, out-of-pocket cost. How do you prevent this? And again, it's really great to incorporate these questions into your counseling for patients. But what I also learned was there's a gap between what patients know and what the understanding of the medical evidence. We have hundreds and thousands of scientific studies on urinary incontinence, but we need to put it in a way that they can understand. And so I'm working on a new patient-centered outcomes research project in which we're trying to get the word out about pelvic floor muscle training for urinary incontinence in women. And so we're engaging patients and different collaborators to produce digital urinary incontinence resources on the benefits of pelvic floor physical therapy, translate this evidence into things that in a way they can understand. And so we're actually doing podcasts, handouts, and trying to get this through. So we're just in the still in this process. So this is our project team and all our collaborators, national organizations, the Urology Care Foundation, the Patient Advocacy, and my institution. So I wanted to also talk about urge incontinence and overactive bladder. That was some of this applies to all urinary incontinence, and some of what we just talked about was stress urinary incontinence specific. But overactive bladder is extremely common. The mainstay is fluid and behavior modification, urge suppression, bladder training, physical therapy. There's also medicines and different categories of medicines, anticholinergic medicines, beta-3 agonist medicines, vaginal estrogen. And then beyond medicines, we have tibial nerve stimulation, Botox, and sacral neuromodulation. So we have lots of great treatment options for overactive bladder. Um, and one of the things I really like to teach patients, and you can do this too, is teach them about urge suppression. And so you've experienced this in your own life. You get the urge to urinate and it grows and it peaks and then it subsides. Patients are often with overactive bladder are pretty panicky when they get that strong urge and they're rushing to the bathroom at the worst time when the urge is really strong. You actually want to distract the signals, use your muscles and let it calm down and then go calmly to the bathroom. Um, and I think that again, these tips and tricks can really help patients manage it and help them get to the bathroom, especially when they're in the grocery store or when they're out traveling and doing things that they don't have that easy access to the bathroom. This is a very important area. As the data is accumulating on the use of anticholinergics and the association with dementia and cognitive changes. And so for many years, for overactive bladder meds, we had anticholinergics as the only choice. And what we're showing is that higher cumulative anticholinergic use is associated with an increased risk of dementia. And this is just one study, but there are others. And so we're counseling patients on this. Certainly, they're still, you know, being used, anticholinergic medications. They just have to be properly counseled. We want to decrease dosages. We want to maybe avoid long-term use. And we want to avoid it in patients that are on other anticholinergic medications. And we have alternatives now. So that's a great thing. But some people get a great benefit from medications and they want to continue as long as they're being monitored and you're letting them know. I think it is an option, but there is definitely accumulating data on the reality of this. So we know overactive bladder is a huge problem. There is data to show that at 1 to 2 years, about 20 to 30% of patients are happy with meds and they continue to take them. But there are a lot of people who have side effects. They're not efficacious, they're costly, and they want something else. There's also a shifting landscape. So sometimes the medication coverage due to insurance changes year by year, and so we've got to kind of keep up on what's covered and how we can get these medicines to be affordable to patients. Um, I'll talk a little bit about beta-3 agonist. That's sort of that now there's two, mirabegron and vibegron. These are great medicines in the sense that they are effective and safe for patients of all ages, and they don't have that anticholinergic risk associated with them. Coverage is getting better. Mibegron is there's a generic version, and vibegron is not generic, but there are some resources to help get it in the hands of patients. And so I would say we've got great options for overactive bladder medicines. So beyond medicines, we have percutaneous tibial nerve stimulation. This is an office treatment once a week for 12 weeks in a row and then once a month. Low risk, patients really are interested in these kind of therapies. And again, an option for patients who want something beyond. What's happening in our field now is there's implantable tibial technologies. So not only for those who don't want to go in every week, you can actually get a little implant in that tibial nerve area. And the reason why the tibial nerve is utilized is that the tibial nerve actually the signals go up the leg and they interact with the nerves that that help with bladder control. So we've got three different FDA-approved options for implantable tibial. They're little stimulators that go right behind the medial malleolus. They get implanted under the skin. There's some good efficacy, and they've done clinical trials. there's, like I said, there's three different companies that have products out there. And so this is sort of the newest thing in overactive bladder, as they're just like, for example, the latest one just got approved last month. Um, so low adverse event rates, good efficacy, probably, 60 to 70% efficacy in improving urgent continence. Botox has been around since 2011 for neurogenic bladder and 2013 for idiopathic overactive bladder. It is effective, it is safe, low risk of UTI and incomplete bladder emptying, generally an office treatment, although could certainly be done under anesthesia. Average length of duration is 6 months, but can be anywhere from 3 to 12 months. It's a scope in the bladder, and the Botox is injected into the urothelium to impact those receptors to help the bladder hold, have less urgency signaling, less frequency, and less urgent continence. It's a great alternative for people who aren't um, controlled with medications or have side effects from medications. Generally speaking, insurance wants you have tried a med and failed before or have a contraindication before you are approved for Botox. But it is, like I said, a great option for patients and can be life-changing. I like to tell patients it's about 1 to 2 injections a year in the office, with a lot of great relief. Sacral nerve modulation is another great option. It's like a pacemaker for the bladder. Just like some people need a heart pacemaker, this is the bladder pacemaker indicated for overactive bladder, urgent incontinence, fecal incontinence, because the S3 pathway affects the bladder and the bowel, and also approved for idiopathic non-obstructive urinary retention. So it takes those sort of extremes, overactive bladder, not able to pee, and it brings it to the middle. And so what's happening is the signals are in the brain and they're going down the spinal cord and out toward the bladder, and you're interrupting those signals around near S3, and you're floating this little pacemaker wire near them so that the bladder works better and the bowel functions better. This is a small implant under the skin. There's usually a first step, which is the kind of a trial where you want to show 50% improvement or more so that the insurance will cover the full implant. The full implant is the IPG, the implantable pulse generator, the battery, and a lead that floats near the nerve. And so a small outpatient procedure after they've sort of proven that it has that efficacy. What's nice about this technology, while it's been approved since 1997, in 2020, it went full body, they're full body MRI safe. So you can get any MRI, CT, or X-ray with this in. Sometimes you have to kind of go in MRI mode, but at least they can have them. Previous to that, it was MRI head only safe. So they've made advancements in technology. These batteries are lasting 10 to 15 years. They're called recharge free or primary cell. So they just kind of get placed under the skin and do their job. Really, again, life-changing for patients who choose this route. This is our paper or manuscript on this. You can see that picture shows a little lead right in the S3, and it's kind of floating near the bladder nerves. And here we're getting 89% responder rate for people who have this therapy. And this was a study looking at sort of optimized lead placement. Like if we put the lead in a really good spot, it's going to do a great job with patients. So this was a contemporary cohort, just because some of the studies were older and had different techniques. This is the sort of modern day technique. All right. I'm going to talk about the genitourinary syndrome of menopause, which is a very important topic that affects overactive bladder, urinary incontinence, and sort of the whole pelvic floor area of patients. Why this is timely is that the American Urologic Association, the Society for our Urodynamic Society, our subspecialty society, and the Urogynecology Society collaborated and came up with these guidelines and released them in 2025. So in May of 2025, now they're fully available. I highly recommend you look at them and read them. They're just a wealth of information, and it's evidence-based. It's been like a collaborative, multidisciplinary collaboration. They were internists on our panel. It's also been endorsed by the sexual health societies, menopause societies. And so I wanted to kind of go over some of this as well. So one of the big areas of this is that in patients with genitourinary syndrome of menopause and recurrent UTIs, Clinicians should recommend the use of local low-dose vaginal estrogen to reduce the risk of future UTIs. So there is a great deal of compelling evidence that this helps recurrent TIs in the perimenopausal and postmenopausal women. Um, this is an unpublished study, but it was an abstract at our national meeting showing that in 11 million women collected from EPIC, this Cosmos analysis, they compared it to premenopausal and postmenopausal people using vaginal estrogen and not using vaginal estrogen. And in the vaginal estrogen users in postmenopause who are postmenopausal women with recurrent UTIs, there was a 22% risk reduction in hospitalization, 51% risk reduction in sepsis, and 73% risk reduction in mortality. So this is real benefit with something that's very implementable. So what is a genitourinary menopause as a review? Is a common underreported condition, thinning and drying and inflammation of the vaginal and vulvar tissues due to decreased estrogenation. It can cause daily symptoms, dyspareunia, urinary symptoms, and vulnerability to UTIs. Highly prevalent, 50% of midlife to older women suffer from these menopause-related GU symptoms. It occurs in the majority of women, but not all are symptomatic, and it can be progressive and less likely to resolve without intervention. Whereas as women who are postmenopausal, vasomotor symptoms tend to abate, these tend to persist. So why is this? This is because estrogen is the predominant regulator of vaginal physiology, and it's present in premenopausal women. And you have a high estrogen environment before menopause, a low estrogen environment postmenopause, and you lose those superficial cells. So it causes real changes in vaginal anatomy. This diagram is the vaginal canal on the left that's premenopausal and then postmenopausal on the right. And you're going to lose the vaginal fornix. You're going to lose or have thinning of the vaginal wall, reduced blood flow, loss of the rugae, that kind of nooks and crannies and lumps and bumps of the vaginal canal that are protective and functional. You're going to actually decrease vaginal length, and you're going to get atrophy of the labia minora and majora, and narrowing of the vaginal introitus and canal. So real changes. I like to explain sort of the effects of GSM. Um, we really know more about the microbiome of the vaginal and pelvic area and pelvic floor. The dominant constituent is lactobacilli, and we need that to produce lactic acid to ensure this optimal pH, which is protective. So if you look at this diagram, at the top it says low estrogen, and on the left side it says that then leads to thinning of the vaginal epithelium, decreased exfoliation, decreased glycogen production, decreased nutrients for lactobacilli, decreased lactic acid, increased vaginal pH, overgrowth of bacteria leads to UTIs. On the right side, you have decreased vaginal folding, decreased elasticity, decreased secretions from the Bartholin's gland, increased traumatization, dyspareunia, infection. So that's the cascade effects of GSM that we have to be aware of. I do want to mention trauma-informed care. I think, one of the things we have to know is just be sensitive and aware that it is a very um, common that women have some history of trauma and abuse of the pelvic floor, and we just have to be supportive and engaged about this, and create a safe environment to talk about it and or do exams. We talk about the GU syndrome menopause and doing an exam and looking at the tissues, but they can also be traumatic. And these exams can lead, trigger patients and lead to anxiety. And so we certainly want them to feel safe. I often, just ask, do you want to do it today? Do you want to do it another day? We don't have to do it at this moment. So you feel ready. Certainly you can ask about having and provide a chaperone. I often use a mirror so we can educate and show them what's going on. They can even self-guide the exam and show you what they're concerned about. I just think there's a lot of things you have to think about: their privacy, their sensitivity. And I often just say, like, we're going to just do a gentle exam when you're ready, if you're ready, and give them a lot of choice and power. So this is some of the best practices Genital exams trigger flashbacks and increase symptoms of anxiety in about 50% of people who have experienced trauma. You want to perform these exams with patients, ensure that they feel safe, have control, and are offered choices. Let them choose the timing of the examination. They can have a support person there. You should leave the room and let them disrobe and dress. This allows them kind of to support their dignity and allow them time to formulate questions. You should cover their body and expose only the areas necessary for the shortest period of time. And then I always have them get dressed and then so then after the exam, and so we can discuss things when they're fully dressed and feel comfortable. All right, back to GSM. The symptoms of GSM include vaginal dryness, pain during intercourse, dyspareunia, vaginal irritation, discomfort, and urinary symptoms, urgency, dysuria, recurrent urinary tract infections, urge incontinence, and stress incontinence. Um, and again, can be nonspecific, and there's certainly other symptoms that could be attributing to this, but you can have that feeling of discomfort or pain, bleeding, decreased sexual symptoms, irritation, burning, itching, dysuria. It can feel like a UTI. And so this is certainly on the differential for someone who feels like they're having a UTI or having frequent UTIs. It's also overlapping with overactive bladder. It can feel like urgency frequency, like you can feel like something's there, your bladder's upregulated or the tissues are upregulated. I also want to go over some of the signs. You've got decreased moisture, decreased elasticity. It can be pallor or erythema. It can be pale or red and bright red. There can be tissue fragility, fissures, petechiae. One of the things I wanted to mention was urethral caruncles or eversion or prolapse. So a urethral caruncle is the inner lining of the urethra pooches out a little bit because it's lost its elasticity, it's lost its estrogen. It's often asymptomatic, and it's just a sign of low estrogen in the tissues. Whereas urethral prolapse is actually the circumferential sort of eversion or kind of protrusion of the inner lining of the urethra. So again, I get consults for this all the time, but often the patients aren't really bothered by it. They just need the reassurance, and the treatment is vaginal estrogen. In and around that area will help prevent it from getting worse. And if they're symptomatic, it will help them feel better about it. We also see that loss of hymenal remnants, prominence of the urethral meatus, introital retraction, recurrent UTIs. So these are this sort of is an encompassing potential clinical diagnosis that affects a lot of symptoms. So GSM, genital urinary syndrome of menopause treatment key points. The primary goal of treating symptomatic GSM is to alleviate symptoms, and it's to use shared decision-making to alleviate their goals and improve quality of life. We're going to educate people on the diagnosis and the safety and efficacy alternatives. First-line treatment is local vaginal estrogen, a cream, a suppository, or a ring. They've been shown to be equally efficacious. And so usually I go with what the patient prefers, what their insurance covers. And you really have to give them usage instructions so they really understand how to use it. And you do have to clarify it's different from systemic estrogen. Systemic estrogen is for hormone replacement or treatment and is designed to be systemic. Local vaginal estrogen is designed to be local. You can be on both if appropriate or one or the other. I will say one of the main patient concerns is it safe? And their concerns about the risks. And so there's a growing body of literature that low-dose local vaginal estrogen does not increase the risk of primary breast cancer, does not increase the risk of recurrence of breast cancer in women with a personal history. It is also safe in women with a family history and does not increase the risk of endometrial hyperplasia or endometrial cancer. The serum estrogen levels with use of vaginal estrogen are below the average level for postmenopausal women. And certainly if there's an estrogen-dependent cancer, you can co-manage this in a multidisciplinary way with their oncologist. Postmenopausal women with undiagnosed vaginal or uterine bleeding should certainly be evaluated as standard of care. There is a black box warning on all estrogen formulations in the US. This is very confusing for women because while this exact data doesn't apply to vaginal estrogen, it is put on all prescription inserts. And so you do have to preemptively talk about those with patients. Otherwise, they're going to be very concerned about using it. And so I often explain the difference. And we've done a lot of advocacy on the urology side to actually get this warning removed from vaginal estrogen. And we have heard from the FDA chief that this is forthcoming. We don't know the timing. It could be very soon. It could, but they're trying to, again, remove these barriers for women. I wanted to mention some of this vaginal estrogen safety data. And this was part of the guidelines. Clinicians should inform patients of the absence of evidence linking low dose local vaginal estrogen to development of breast cancer. Because, we as clinicians have to feel comfortable with this, and our confidence with it is translated to the patients. So this was a secondary review of a WHI observational study in over 45,000 postmenopausal women at baseline with a self-reported use of vaginal estrogen, and the risks of invasive breast cancer, stroke, endometrial cancer, colorectal cancer, and venothrombus embolism were not elevated among postmenopausal women using vaginal estrogen compared to non-users. And the risks of cardiovascular disease and all-cause mortality were also lower in vaginal estrogen users. This was the Nurses Health Study published in 2018 of postmenopausal women with over 18 years of follow-up. Vaginal estrogen use, in the absence of systemic estrogen use, was not associated with a higher risk of cardiovascular disease, breast, endometrial, ovarian, colorectal cancer, or hip fracture. This was a 2020 retrospective cohort study of gyne cancer survivors, endometrial, cervical, and ovarian, who had been treated with vaginal estrogen with a median follow-up of almost 7 years. The overall incidence of cancer recurrence was low and comparable to expected rates. This was a 2024 large registry-based nested case control study using data from Danish national registries to look at the rate of breast cancer associated with the use of low-dose vaginal estrogen tablets, looking at the duration of use and the intensity of use. And in almost 19,000 women who developed breast cancer, they were matched with women who did not, and there was no increased overall risk of breast cancer with long-term use and high-intensity use. This was another guideline from our study, or from our guidelines panel. For women with GSM who have a personal history of breast cancer, clinicians may recommend local low-dose vaginal estrogen in the context of multidisciplinary shared decision-making. This was a 2023 large claim-based analysis and nested cohort study in the US with over 42,000 women diagnosed with GSM following a breast cancer diagnosis. There was no increased risk of breast cancer recurrence within 5 years of women who had a personal history of breast cancer who used vaginal estrogen therapy compared to non-users. In this particular study, people who had concurrent aromatase inhibitor use, there was a slightly higher risk of recurrence. But the next study is going to show that to be different. So this was a cohort study using linked population-based health records from Scotland and Wales. Was 49,000 women, 40 to 79 with newly diagnosed breast cancer. And there was no evidence of increased risk of early breast cancer specific mortality associated with the use of vaginal estrogen therapy. And there was no increased risk in estrogen positive breast cancer and women who were using aromatase inhibitors. So again, the data is, I'm trying to show you the best studies so that you can see what's out there. And that is one area that we are still following, but I do believe it's safe, again, in the context of the individualized patient and the counseling and their comfort and their situation. This is a systematic review from 2025 that shows, a systematic review and meta-analysis of 8 observational studies comparing female breast cancer survivors who use vaginal estrogen to those who do not. There was no association with breast cancer recurrence, no increased risk of breast cancer specific mortality, and no increased risk of overall mortality. So again, lots of data to show the safety of vaginal estrogen and when we talk about the context of cancer. And so I think that we can be assured in the safety of this. Wanted to talk about the patient perspective about there's really a low awareness about vulval or vaginal symptoms postmenopause, and specifically the genital urinary syndrome of menopause. They may be unwilling or embarrassed to talk about it. And 75 of women with the signs and symptoms of GSM do not seek help from providers. So this was a study where we looked online and what they were talking about on Reddit, and they were just highly engaged and passionate and had a lot of questions about medication usage, medication side effects, medication alternatives. They expressed frustration with the medical system, and they really were seeking validation. And so why I like these studies is because then I can counsel patients to these questions. So if they have a lot of questions about sort of the nuances and specifics about medication usage, we go over it when I prescribe it. I talk about if it's a cream, I want you to put it on your finger and put it inside and rub it in twice a week at night so that it has the most benefit. You can also use it on the outside. Again, it depends on their symptoms and their anatomy. I also talk about expectations. So it's not going to be instantly helpful. It's really going to take, 2 to 3 months to get the full benefit because we're changing the tissues and we're trying to improve them. We talk about side effects because they're very concerned about what this might cause. Hormones kind of lead to that sort of fear and misunderstanding. And so I ask them, like, what are you concerned about or what are you worried about? And then we speak to that. And there's alternatives. What are the alternatives to these symptoms and these issues? And yeah, they really want to know, like, well, so some of them maybe want non-hormonal alternatives. We can talk about moisturizers, lubricants, hyaluronic acid, different things that might help them. And I think the frustration with the medical system is just, they want to feel heard, validated, and supported. And so feeling blown off or feeling like they're not taken seriously was a lot of the conversation. And then they got a lot of validation from their peers online. This was a follow-up study where we did a questionnaire to women on a national scale, 1,500 women. And what we learned was that there was a financial cost and concern about side effects using vaginal estrogen. And again, they felt like their symptoms were not adequately addressed. And again, we can have a role in adequately addressing them. We can, bring it up and help them get what they need. They had concerns that these specific concerns were not being taken seriously. They had concerns about breast cancer, endometrial cancer, and cardiovascular side effects. And they felt that the prescriptions were somewhat financially burdensome, somewhat to extremely financial burdensome. And I will say the prescription coverage and the cost of vaginal estrogen has dramatically improved over the years. And so it is an affordable prescription now. There's often a formulation that's covered on their insurance plan. There's also online options. For example, the Mark Cuban Cost Plus is selling it or just above cost. And so you can get this vaginal estrogen at a good rate. And sometimes I just like to ask the patients, like, what is it costing you a month? And they'll tell me, and I'll say, you know what, actually, for what this is doing for you, I think that's a fair and good price if you're, and I kind of talk through it with them, um, and so that they feel comfortable with what they're doing. Another question they often ask is, do I have to take this forever? And I never like to say it's forever, but I would say for right now, you're getting the benefit, or I want you to get the benefit. And so I would definitely say for the next 3 to 6 to 12 months, let's keep going. We can always reassess. But it is generally a long-term medication that's safe and helping you, especially if someone's symptomatic or has recurrent UTIs. I would say, we put moisturizer on our face for long term. We brush our teeth long term. This is for the benefit it's getting you. Let's consider this. This was a study that showed that patients, depending on their health literacy, they sometimes have poor recall of pelvic floor conditions just because it can be confusing. And so patients with pelvic prolapse actually had worse recall and disease understanding than patients with urinary incontinence. And so again, we have to meet that gap and help them understand what we're talking about. And so I know we just have a few more minutes, but I wanted to just briefly talk about prolapse because it can be confusing because patients often think prolapse and incontinence are the same thing, and they're different. Prolapse is the bulge of vaginal tissues coming out of their body. Urinary incontinence is the leakage of urine out of their urethra and bladder. And so prolapse is also, and your overactive bladder, that urgency frequency are actually two separate things. And I have pictures of buckets here because I was like, you have different buckets, you have different diagnoses. You have prolapse, you have overactive bladder, you have incontinence, you have recurrent UTIs. They're all separate. They're related, but they're separate. And I say they're separate so that we can treat each of them separately and give you the right treatment options. Prolapse is also not bowel incontinence. It's not constipation. It does not cause your UTIs or bladder infections. And it's different even from postmenopausal vaginal atrophy or GSM. The tissues are the low estrogenation is the genitourinary syndrome of menopause, and people with prolapse often have that, but the prolapse is truly the organs are out of place and bulging. So prolapse is an anatomic problem that involves the lack of support, and then certainly we can restore that anatomy. What does prolapse feel like? it can be symptomatic. It can be not bothersome. They can have mild prolapse within the vaginal canal and it doesn't even bother them. It can be intermittently bothersome and somewhat noticeable at times, but the most common symptom is a vaginal bulge. They feel like something's there. When it becomes symptomatic, it's usually at or beyond the vaginal opening, so they can feel it at the opening, and it's sometimes coming out. It can be the uterus, it can be the bladder, it can be the wall between the rectum and the vagina. It can feel a pressure, a heaviness, or a falling out feeling. Sometimes it feels like they're sitting on a ball, and they can see it and they can feel it. And sometimes they can have difficulties with bowel movements or urinating um, because of that. The organs are out of place. It's very common. Over half of women over 40 have some form of prolapse on exam. And when you define it by symptoms, however, the prevalence goes way down. And certainly just a subset need prolapse surgery. I will say this is kind of a theme here, but we need to be sensitive to the emotional and sort of psychological social needs of these patients because there's again a delay in seeking care, embarrassment, misinformation. In this case, it's often a fear of it getting worse. And it's also tied in with sexual concerns and it affects their ability to be physically active. Honestly, so does incontinence. But truly, they just want to feel better and have their symptoms treated. This is another qualitative studies where they talked about how debilitating and prolapse was, and they wanted to know more. They wanted more support and care. They were very self-driven, and they really wanted people to know about the benefits of pelvic floor physical therapy to treat their symptoms. So, what are the treatment options? They can be conservative, pelvic floor physical therapy, pessary, or surgical reconstruction. We generally potentially recommend or counsel them on surgery if it's stage 2 or greater. And stage 2 means it's at the opening or beyond, outside. There's vaginal approach, there's robotic approach, but the key is really getting that really supported inside in a durable way. And there's a very high satisfaction with the relief of prolapse. Sometimes it's multidisciplinary. We use our colorectal colleagues if they have a lot of bowel symptoms or rectal prolapse as well. So the take-home message is that pelvic floor problems are very common. We want to ask how bothersome it is. How is it affecting your quality of life? There is multidisciplinary care with subspecialty expertise. The treatment ranges can go from conservative to medical to office-based to minimally invasive to complex surgical reconstruction. We really have to individualize the care that we provide and do a lot of counseling to get to their goals. And I always ask, what bothers you? What matters to you? How can we partner together to get better? I would say, I've been in practice over 15 years, and there's some learnings here that I've gained over the years. I always try to ask and listen, and I'm just becoming more and more open-minded to patients' unique viewpoints, goals, and priorities. I really want to believe them, and and give them hope. Um, I meet them where they are. I speak to them in a way they can understand. I try to anticipate common questions, fears, myths, misunderstandings, so that we can educate them on the why. If people know the why, then they are more likely to follow through and stick to it. And we talk about real world expectations and outcomes. I want to give my patients choices and empower them in a way that they can understand so they can make informed choices about their bodies and their symptoms. Um, this was a word cloud generated. We did this event where we improved the patient experience with cystoscopy, and these were some of the words they come up with. Every clinic visit is an opportunity to improve your patient-clinician interaction. Again, to listen, to understand their knowledge and concerns, educate and empower them. We really want to create satisfying and even remarkable healthcare experiences, and every visit is an opportunity to do that. Bill Clinton had this kind of gift of like connecting with someone for a short time, but making them feel really valued and listened to. And I think we could definitely do that with our patients. This was a bus that drove by one day after I was working on this, and it said, "What if every patient felt like the only patient?" I would love for patients to feel that way. And this is one of my favorite quotes from Maya Angelou because patients truly define the value in healthcare. I've learned that people will forget what you said, people forget what you did, but they'll never forget how you made them feel. And so we want patients with pelvic floor problems or urinary incontinence or honestly any healthcare issue to feel that you cared and that you wanted to help them. This is our pelvic floor team at Virginia Mason, urologists, GI doctors, colorectal surgeons, gynecologists, pelvic floor physical therapist, and we really work together and try to help people in the best way possible. These are just my acknowledgements. I've been with Virginia Mason Franciscan Health for over 15 years. We worked together in a very subspecialized way, and it's been very gratifying, and I'm really grateful for that to my mentors, my colleagues, my research collaborators, my patients, and my family. Thank you.
Una, thank you so much. This was a fabulous talk and really such a beautiful way to end as well. I feel like I certainly can speak for myself, but I'm sure others that a lot of the messaging you closed with just really resonates with trying to counsel patients in an effective and patient-centered way. So thank you. And thank you for your time. There are many questions. So if you have a few minutes, I'd love to just
Yeah.
maybe ask a few. I think one I'll start with just, you were just talking about GSM. And I think a couple questions related to that. For women who have been, I think questions kind of getting at like other things beyond topical estrogen and like the order in which you might consider that. So for people who have been on topical estrogen or maybe having a hard time adhering to it for various reasons or just are like persisting symptoms despite being on it, think just asking questions about like e-string, like the vaginal ring, lube or moisturizer if you have like ones you prefer that are over the counter that you would look to. And then another talk earlier brought up DHEA as a recommendation that could be considered. So just if you could speak to things beyond the use of topical estrogen for GSM.
Yeah. So I think for topical estrogen, vaginal estrogen, we want to review what they're doing because sometimes they're not using it consistently. And often I'm just the cheerleader for being consistent with their use. But sometimes we do change formulations. You can increase the dosage, you can individualize the dose. It's very safe. So sometimes they're like, I do it once a week or twice a week. You could go to 3 or 4. You could do it daily. You could do, a small amount daily. S-string is a great option. E-string is a good option. It's the ring that goes in every 3 months. If we can get it, covered, it helps with compliance. The suppositories are great. I mean, you can even do suppository in and cream on the outside. I mean, there's lots of different ways you can individualize it. And so I definitely go over the exactly what they're doing and I try to optimize that. But you can change formulations based on preference and insurance coverage. It's like I said, it has gotten better. DHEA is another option. It's a daily insert. Sometimes it's hard to get covered, but it is an option. It is local and it has some benefit for the refractory patient. Um, if I could give it to everyone, we could give, that would be great, but it's not, it's a little bit harder to get right now. It probably will
Mm-hmm.
improve. You mentioned lubricants and moisturizers. So you think about lubricants as episodic use, like you're going to use that for sexual activity. Moisturizers are like moisturizers, right? They're going to
Mm-hmm.
actually over time change um, and help moisturize. But
Mm-hmm.
vaginal estrogen definitely has the best data of improvement.
Got it. And are the
Uh,
rings still considered topical, or at that point, are you then thinking about if those patients are safe for more systemic estrogen?
so the E string is a local. The Nuva ring is systemic. So that's what's confusing. So there are
Okay,
systemic rings and then there's local rings. So you have to kind of make sure you're what the purpose is and
picking.
what you're doing. Yeah.
Great. That's super helpful. And then someone asks, does systemic estrogen alone help GSM symptoms without the
That's
topical?
that's a high level question in a good way. There is some data that show that systemic estrogen helps. But really, if they're having symptoms, I would go with some local treatments.
Okay,
Yeah.
great. And then one question, just kind of pulling back to the incontinence talk, or the incontinence piece you had there. Somebody says, I have a much older patient population who often have mixed um, urinary incontinence and mild cognitive impairment. It's so hard to prescribe Ribetric or Gemtesa because of insurance covers the anticholinergics and they can be expensive. How do you navigate some of this?
Yeah, this is like my daily life. But so my Betric is a generic and it has coverage has gotten better. So both Mirabegron and Viragron are really trying to get it into the hands of patients because the safety profile. So it is the ideal situation for older patients.
Mhm.
And so I've actually had to learn like about how to navigate this and your pharmaceutical reps can help navigate that. They have some tools. Um, I'm also sometimes offering Botox or other things that, if you really want, if they're bothered and they need improvement, sometimes we move on to things beyond medicines. But I do think the right thing to do is to try to work through the process for beta agonist. I think it is the right thing to do to help people.
Okay, great. Well, we are right at one, so I want to be respectful of your time and all of our participants. So I will wrap us up. But yeah, Una, thank you so much. That was such a fabulous talk. All of our talks this morning have just been really, really helpful. So much great data to take in. Thank you again for joining us, and for all of our participants. If you want, the slides will be available as well as some of the CME that you can claim all through that pre-course website. But I think at this point, I will close us out, and hopefully we'll see many of you through the ACP conference through the rest of the weekend. Take care, everyone.
Thank you so much.
Thanks.